I'm Jennifer Potter. I'm an associate professor. I thought did that say assistant? Associate professor in the Department of Psychiatry over at the medical school. And I'm also the assistant dean for research. So I will put in a plug right now. If any of you are research faculty or involved in any research, we have 2 new calls out right now for pilot studies. So in my effort to try and promote those, and if you haven't seen those emails come out and you're part of our faculty, I would encourage you to take a look at those. One of them is a very large award for $100,000, and then we have some smaller ones up to $50,000. Okay, so what we're going to talk about today is a bunch of things about chronic pain and substance use disorders. And so this will run the gamut. I was trying to think about what would be best to present, and it occurred to me in this audience you might have individuals with substance use disorders as their primary presenting complaint who have chronic pain, and then potentially folks with a history of chronic pain who may be exhibiting some questionable activity or may be on their way to developing a substance use disorder. And while much of this does not directly address issues in the elderly, I will call it things out as best I can for Mark on the topic. But what I will say to that point is that there's an emerging literature, but very little known about, unfortunately, elderly substance use, with the exception of we know that this is actually happening a lot more than one might think, and it has to do with prescription medications and their misuse. So we'll try and go through that. So I am involved, I've been doing substance use research for a number of years now, and I was fortunate to obtain a career development award from the National Institute on Drug Abuse a number of years ago. And the reason I got interested in the topic is coming out of the substance use field. I was working at McLean Hospital up in Boston. It's a teaching hospital at Harvard, and that was where I was doing my postdoctoral work. And what we started to see on the detox units was all of a sudden these people, if I, do I need to stand up? Is it all right if I sit? Do you want me to stand? No? Okay. And the other thing I should mention, since it is a cozy group, I'm more than happy if people want to interrupt and we can chat about something. There's that handout there, 88 slides. I will not do 88 slides, but I had some in there in case some topics came up, so I could refer to those. So anyway, I was on doing my typical things and doing the research activities, and I'm a clinical trialist largely in what I do in my research. And we started seeing, and this was back in the early 2000s, there were all these people coming onto our units that weren't like the people that we usually saw. And the most clear thing about them was that they were all misusing prescription opioids. So people started coming in looking for a detox from opiates. And the order of magnitude that was so much greater than anything we'd ever seen before. And in Massachusetts, we had a significant problem with Oxycontin. So Massachusetts was really one of the places in the United States that really struggled with Oxycontin. And in fact, if you're familiar with the Boston area, we have a road that the highway around the city, there's one that goes straight through the city, that's 95, and then the one around, no, I'm sorry, the one that goes through it is 93, I haven't lived there in a while, and the one that goes around the city and goes through the largely affluent suburbs surrounding Massachusetts, our technology highway is 95. And if you looked, there was no difficulty in the urban center of Boston, Massachusetts, but going through those affluent suburbs on I-95, there was this tremendous spike in opiate deaths, opioid misuse, and treatment seeking, all related to Oxycontin. So we really were part of that wonderful journey in the early 2000s of watching people's lives dramatically change as a result of Oxycontin. So lo and behold, a lot of those folks had pain. And that was not something that we were typically dealing with in substance use, although it's more than we realized, but it really highlighted this issue of co-occurring chronic pain and substance use disorders. And one of the most compelling moments I had was when I started doing this, we did some qualitative research, and we wanted to talk to these folks to better understand what their stories were and start to learn more about that. And what we realized was that one of the first qualitative interviews I was doing, I pulled people off, I found in their charts that they had chronic pain, and then I asked if I could speak to them. And then I started talking to them, but really all I was talking to them was about their pain. And at the end of the first or second one that I did, somebody said to me, can I ask you a question? Why are you asking me about this? Why are you asking me about pain? And I was really struck by that because to me it seemed fairly obvious, and they said that they hadn't really had anyone feel, they hadn't felt like anyone had actually asked them a question about pain really since they've been on the unit. This is a typical detox unit. Now again, this is before the JACO policies, it was before pain is the fifth vital sign, but it still spoke to me of that disconnect between chronic pain as a reason for substance use and how that might lead someone down a slippery slope. And it also creates a challenge for us clinically in understanding when someone has a substance use disorder, how do we address the fact that they also have pain? Because at least in my world, which is addiction, typically you hear on the units, they're med-seeking, they're drug-seeking, they just want pills and they're moaning, they're exaggerating their pain. And now, this was again in the early 2000s, we've really changed our approach to that. We have a different ways of assessing pain and appreciating it, but it still speaks to this idea of what do we do about people who have very valid self-reported pain, but also have a substance use disorder that may or may not put them at risk if we give them an opioid. And over the, now it's 2015 and hopefully we know a lot more. I think one of the good things about the epidemic of prescription drug abuse in this country is we've learned some things. We have a long way to go, but we have a lot better approaches for thinking about this and some decision making about it. So this is one of those folks that I interviewed. It was a long time ago, but what's interesting is depending on who you are as a clinician and where you come from on this issue, you can see something very differently in this. So when I see this, if I put my addictions hat on, I see, oh, they're thinking about pain, that's obsessive, how am I going to get rid of it, when is it going to go away, why me, it consumes you, it eats up all your time. And I key in on the it consumes you, it eats up all your time, because if you go back to our diagnostic criteria for a substance use disorder, that's the type of thing that you're looking for diagnostically when you're making that diagnosis. But you can also see in here some things about pain that if I can get 50% pain relief, that person is actually more self-aware in some ways than many people with pain, where they're even thinking on a continuum as opposed to, I want a cure for this pain. And we know about chronic pain now that it's not something that actually goes away that often. And particularly as we'll talk about, that opioids very, very rarely give 100% pain relief for a chronic pain condition. Nor are they evaluated that way by the FDA. 100% pain relief is not the metric by which an FDA-approved opioid analgesic is brought to market. So we have these false expectations. So it's intriguing, it's messy, and trying to unpack and untease what's an addiction, what's misuse, and what's pain relief has gotten very mucky, and I don't think we've wound our way out of that mess quite yet. So, as I've already been alluding to, one of the things that I've been fortunate to have, because I've had training in pain medicine as well as in substance use disorders, is I go to different meetings and I see different audiences. And depending on how you look at this elephant, you see very different things. So for a long time in the history of pain medicines, and we can go back to some of the work by Russ Portnoy and folks where we were citing articles saying, opioids are safe for chronic pain. Don't worry about that. And that was a little bit of a Pandora's box, as it turned out. On the addiction side, if you go to an addiction meeting or talk to people, on the addictions it used to be, it's changing now. Very much they're not safe, we don't want to do this, minimize, minimize, minimize. They're addictive, but we need to address people's pain. And that's the quandary that we've got. And the argument really is that, this is my only funky animation, it took me a long time to make this slide, a while ago, is really that it depends. And I really, really encourage folks, particularly in the type of work that you all do, that it's really understanding the context in which the behavior occurs. Okay? And again, I'm sure I'm preaching to the choir, but it really is about the context and understanding that. What we know from addictions is when direct confrontation typically does not work when we're challenging someone. Direct confrontation tends to make that person defensive and shut down. And so I really encourage folks to take a contextual view of what's going on. I don't need someone to go, yes, I'm an addict, to help them with their problem. We can focus on behaviors, we can focus on things that might be causing problems in their life, and less about that direct confrontation. And what we know from the research is that actually can often be more successful, and you spend a lot less time doing that when you roll with their resistance rather than trying to confront them. So I don't really argue about this anymore. I really think about it as we have to understand things contextually, what works best for whom in that situation, and that the situations change over time and we need to be adaptive to it. So again, I'm sure y'all are very familiar with this. This is to orient you that my approach is I think about physical pain. This is the IASP definition from '94, an unpleasant sensory and emotional experience associated with actual or potential damage, tissue damage, or described in terms of such damage, and that chronic pain is continuous or recurrent pain persisting 3 months or more. There's a lot of different definitions. We talk about pain as this one category when actually there's a lot of different pain phenomena that rest underneath that, and I don't mean to dilute that, but this is generally speaking, as I'm going through this, where I'm coming from. Implicit in this is that I can't always see this, and so when we assess pain, obviously we take and we want to respect, including for people with a substance use disorder, their reported pain and validate that pain. And so there is, when somebody says they're in pain, the general approach is that we take what they're saying is they're in pain. We might not know the degree of pain. We might question some of the ancillary benefits of mentioning pain and the functional relationship between that and drugs, but we still have to just take someone and say they're in pain, and they're going to rate that pain subjectively. So that's our pain definition. I don't know how many people have had an opportunity to sit down and really absorb the DSM-5 substance use disorder criteria in a while. I can't believe that you don't spend your time looking at diagnostic criteria. There are a couple changes that are important, so I just want to highlight those. First of all, abuse and dependence are gone. There was this very big backlash against using dependence so I used to say someone was opioid dependent in my world, and opioid dependence meant that they met criteria for substance use disorder. The problem with dependence, as I'm sure many of you are familiar, is that physical dependence, yeah, it gets very confusing, and so it's the only time I've ever had a round of applause. Actually, I've had two now. But I had one round of applause in the middle of a talk, and it was when I was at the American Pain Society meeting I was presenting, and I said I was going to use the word addiction, not dependence, but I was referring to these diagnostic criteria because they were very pleased, and I know frustrated in that particular society about this use of the word dependence. So dependence is gone when we talk about substance use disorders. What we have now is no longer abuse as well. We have what's called a substance use disorder. So in the case of opioids, it would be an opioid use disorder. So this is the criteria by which we are currently evaluating opioid use disorders. We have, we have opioid use, using larger amounts or for longer time than intended. That's the way it's always been. We have persistent desire or unsuccessful attempts to cut down. That's the way it's always been. Great deal of time obtaining, using, or recovering. Again, that's a criteria we always had. And it used to be we had 7 criteria, and if you met for 3, you met criteria for an opioid use disorder. Welcome to the world of psychiatric diagnosis. But the 4th is different, okay? So this is a new diagnostic criteria, craving, okay? And that's an important one because there was this consensus that, it was controversial, but the consensus was this phenomena of craving was sufficiently well characterized so that we could say that was a diagnostic criteria. The failure to fulfill major roles, again, that was there before. Persistent social or interpersonal problems caused by substance use, that was there. So the only one I'm mentioning there that's new is this craving. The key is how we make the diagnosis that's changed. Social, occupational, recreational activities given up, using in physical hazardous situations. My favorite one was riding a bike, but driving a car or anything like that. And using despite physical or psychological problems caused by use. So again, at that point, there's only one new thing we've added in craving. The new caveat is tolerance and withdrawal have changed. In the old DSM, there was no qualifier for, as I'm pointing out here underneath, tolerance and withdrawal are no longer necessary or required or appropriate to use in diagnosing a substance use disorder if the opioids are taken solely under appropriate medical supervision, okay? And this gets back to that dependence piece, which is why I'm highlighting it. So when someone is receiving an opioid by prescription, those 2 diagnostic criteria should not be used in evaluation. It's not perfect, but it's better, and I think it's an important change. Does that all make sense to everyone? Okay. The other place in how we diagnose this is it's no longer 3 and you're in, and that's it. Because what we know is that many people that I assess will have 6 or 7 diagnostic criteria, and so 3 didn't really have this value. So what we've done now is that 0 or 1, if you have 1 criteria for a substance use disorder, you don't need criteria, you're sub-threshold. But if you have 2 or more, you're now going into some severity buckets, with mild being 2 to 3, moderate 4 to 5, and obviously severe is 6. I actually really like this because what that means is setting aside reimbursement issues and things like that. What that means is that you can work with someone with 2 or 3 symptoms and discuss it on a continuum and then look at people. So I think this actually makes the criteria a lot more workable and useful than 3 and you're in, 2, you're out. So this is how the diagnosis is made now. What that does do, though, is I think it creates a diagnosis for many people that we would not necessarily otherwise have thought of as being, you agree with that as in having an opioid use disorder. So it opens that door. And there's all sorts of controversy about that, but that's for another day. So again, I've already hit this hard. Physical dependence does not equal substance use disorder, and I think this is tricky. It's confusing for patients, it's confusing for family members, it's confusing for the community, and even clinicians, I think, can fall into the trap of doing this, and so I think it's important to draw that distinction and just highlight it. Okay, so in terms of the scope of the problem, I'll give you a little bit of some epidemiology. I will say that the take-home message is we continue to have a problem with this. We actually have an interesting phenomenon right now, which is that the rates of opioid misuse and people seeking treatment for a substance use disorder related to opioid analgesics are actually tapering, which makes sense. We're ratcheting back the access. There's a lot more scrutiny. So that's all well and good. What seems to be happening, though, is that we're still having a lot of overdose deaths. The other big picture is that we've got people that are moving on to heroin. So if you look in the Northeast, where there was a very significant problem with prescription opioid misuse, the heroin problem is back, and it's back big. But we are continuing to have heroin-related overdose, and we're continuing to have the problem with overdose on prescription opioids, even though the rates of use are falling back a little bit. Okay, so opioids, in addition to these things, opioid analgesics are the most misused drug class in the United States. And among all drugs of abuse, second only to marijuana. In 2011, the second highest rate of past year dependence or abuse of illicit drugs was seen with opioid analgesic users, with 1.8 million meeting diagnostic criteria. And the new just fact to make you aware of is that opioid analgesics are now the leading cause of accidental death in the United States. They are now ahead of motor vehicle accidents. What's interesting about the prescription drug epidemic is that we're stuck, right? Because prescription drugs are not inherently bad. Opioids are not bad. And I think that unfortunately there's been a message of late that they're bad things. And that's not actually true. They're actually very appropriate medications used for very appropriate reasons. And they can be safe and necessary. And the threat really comes from the abuse and diversion. And so the way that I think about it now is that I really think about, for those that gain access to opioid analgesics as a result of a prescription, if we think of abuse, misuse, and ultimately a substance use disorder as potential side effects or adverse events, we need to treat them the same way that we would anything else. We make people aware, and this is according to guideline, we make people aware of the risk. We do the good assessment that we should do for anything so that we understand when and why they're contraindicated. And we treat them that way. Because really we have no other choice, because it is part of our toolkit, it's appropriate to prescribe opioids, and we're not always going to know the times when we need to do that. And I'll get into some guidelines related to it in a little bit. We do know that so one other thing I was mentioning to Mark when I came in is, depending on the door that somebody comes into treatment or to care, they can look very different. So sometimes, and I'll try and make it clear, I'm just going to toggle back and forth. Sometimes when people are coming into care, they're walking through the door of a substance abuse treatment program or a clinic where that's the primary presenting problem. But sometimes they're walking through the door of a general practice or a pain management program where they're seeking pain relief. These are overlapping groups, but there are some differences. And so right now I'm talking a little bit about substance abuse treatment outcomes. So these are people who are either referred or self-presenting for treatment from substance use. We know from the research that pain continues to be, for someone who's a substance abuser, a primary reason for continuing to use. It's not the number one reason once they meet criteria for a substance use disorder, but it continues to be a primary reason why someone uses. But we also know that just having chronic pain doesn't lead to a poorer outcome for your addiction. So it's a little bit more complicated than we used to think. We used to think if somebody had chronic pain and they came into treatment for a substance use disorder, that their outcomes were inevitably, they were much less likely to respond well to the addiction treatment. And we know that that's not true anymore. In chronic pain patients, psychiatric and substance use histories are predictors of misuse. That has been borne out time and time again. So knowing that someone that you're working with who has chronic pain, has a premorbid psychiatric history, that is a risk factor. The level of precision within that is not very good, but we know that it's a risk factor. It doesn't mean that opioids are contraindicated for them. It just means that it's someone there's a red flag there. And substance use histories are particularly important, even if the substance use history is remote. So they may not say that they have an alcohol. They may not have anywhere in their history, nor will they report an alcohol use disorder or any other type of substance use. If they have a family member that has risk factors, if they have a family member that has had a history of substance use, not opioids, even alcohol or even cigarette smoking actually has been borne out, that's another one of those red flags to just consider. But we still don't have a good sense of what it is beyond that. Okay, so we just unfortunately don't have enough research to tell us what's going on beyond that more global level. So depression, anxiety disorders, when you're giving someone an opioid who has that in their history, that's something to pay attention to, and just keep an eye on. And there's some more guidelines coming up. So this is some more detail. Sorry, I'm not very good with my. Another substance use disorder, we've already talked about that, psychiatric illness. Some other factors that seem to have popped, this is from 2007, Bob Jamison's paper, but this continues to be borne out. Childhood history of physical or sexual abuse, family history of addiction, I've already mentioned. Enabling behaviors, and what I mean by that is if somebody in the family is giving that person additional opioids, if they're helping them to acquire opioids, that's not a good sign for a lot of reasons. Some concerns about harboring meds and taking them all at once. This one is a little trickier because sometimes people, and you may see this, they save their medicines, they might be having a period of time where they're feeling better, they're not using as many opioids, and they're hoarding them a little bit because they know that coming down the road there might be another time where they're having difficulty. It's not ideal, but it's something. It's something that we see. And then using meds to treat anxiety, insomnia, or depression. So if the reasons why they're using the opioids start to drift into these other explanations, that sometimes is thought of as a risk factor as well. And exploring the functional relationship between the opioid use and what's getting in the way, and is that the best thing to help you sleep? If the pain isn't bad, but you're worried about it getting bad, so you're using an opioid to help you fall asleep in anticipation of a problem that might come, it starts to get a little bit murkier why they're using it, and that's a potential opportunity to look at a non-opioid or non-pharmacologic approach to providing some care. Okay, that's it. So a couple things just about epidemiology. So the vast majority of problems in the United States are not with oxycodone or the active ingredient in Oxycontin and other formulations that include oxycodone. The real problem is coming from the hydrocodone, because hydrocodone, just quite honestly, is prescribed a lot more in the United States than the oxycodone products. So where we see the greatest number of deaths is actually with oxycodone products, but in terms of misuse, it's really coming from the hydrocodone, and that's not something magical about hydrocodone versus oxycodone. It's really because there's just a lot more prescriptions for hydrocodone in the United States. But this is my current favorite slide, and even though it's a little bit dated because it's from '09, it just tells such a story. So opioid sales, treatment seeking, opioid sales, and here are people seeking treatment for opioid-related problems, and we know this from nationally representative data sets that monitor the reasons why people are seeking treatment for substance use disorders. And so we saw opioid analgesics as the reason for seeking, the primary reason for seeking treatment for a substance use disorder, following very nicely with those prescriptions. And then look at deaths. So when we think about substance use disorders as a critical public health problem, I don't think it's always one that people come top of mind as being a highly risky behavior, risky disease, but the number of deaths associated with opioids is staggering. We just finished a long-term study following people 3 years after treatment with buprenorphine for their opiate analgesic use. I think in our age group between 20 and 40, we had 12 deaths, which is a pretty high mortality rate in that age It wasn't always opioids, but the opioids we weren't always able to link an opioid exactly to the reason for death, but there were a number of motor vehicle accidents and things like that. Okay, in terms of sources for pain relievers, and I think for y'all this is there's an impression, particularly important, there's an impression out there, and this is from 2011, that originally there was, oh, everybody's getting these opioids through the mail. Do you remember that? You could buy all these drugs on the internet. Or they're getting them and they're buying them illegally and all these things. The reason why there's such a concern and so much concern at the federal level is because where people are getting them is free from a friend or a relative. And that continues to be the case. This was the case in 2008. I think the last time they looked at it is, and it was the case in 2011. And look at drug dealer, stranger, bought on internet. I actually had a colleague of mine publish this in JAMA as a letter. He worked with the post office who controls this to try and buy opioids on the internet, and they had the hardest time because you can't actually try to do this without the post office being involved or you're committing a crime. So the post office funded him to do this study with the Department of Justice, and they were at a lot of difficulty. You could buy things called opioids, but they weren't actually opioids. They were a whole cocktail of things that they were getting, so they did not have a very high success rate in getting a real opioid over the internet, although certainly that can happen. But I think the key public health thing is that they're free from a friend or a relative. This is everything from the mom sharing or the dad sharing it with the college student who hurt herself or himself. It's sharing because you're too busy and you know you've got some in your medicine cabinet. It's a lot of things. People are sharing their medications, and that's a concern. Now, the other thing that's important is, what's the other way to get something free from a friend or a relative? Did you say steal? Yeah. Yeah. So this bucket includes I took them. So it's important to think about that. I do talks to the community, and I think I stole this from somewhere, but it's really about minding the medicine cabinet and really paying attention to, you've got people in your home, you've got young people in your home, if you have friends in your home, I hate to say that, if you have workers in your home or anything, that medicine cabinet where everyone stores those medicines for a couple of years and forgets about them is a really, it's probably looked at a lot more than most people realize, and I try to convey that as much as possible. And that's why San Antonio in the last couple of years, and I'm sure you've heard this or been involved in them, is doing a lot better job on buybacks or takebacks of opioids. And partly that's to keep them out of the water supply and other things. So I think SAWS actually has one coming up in the next couple of weeks. But it's also because getting this stuff out of medicine cabinets and disposing them appropriately in an incinerator is the best way to do that. But if you're a patient who has a prescription, it's very hard. If you take those to your pharmacy, pharmacist isn't going to take them back. So what do you do with them? And so often these things reside in the mortuary in our medicine cabinet. It's also a major public health concern, and I think particularly for older patients, it's important to remind them of this if they have grandchildren. The rate of overdose among children has really gone up, and so the poison control centers are also involved in this effort. So it's not just about themselves, it's not about someone stealing, it's about young people getting access to them, very young people. Okay, and just briefly, I talk so much, I always have to watch my time. I'm about to run out of time, aren't I?
Well, you've got 20 minutes at least.
Okay, I'm going to go faster. I'm sorry. Someone made me do it. Someone asked me to do a talk, and I didn't realize it was 3 hours, and I was so happy because I could fill up. I had enough time to do all my thinking. I'll go faster. So just notice that also it's not doctor shopping, which is another thing that we think is people are going boom, boom, boom. Where are they getting all these things? Because they're going to multiple doctors. And at least among those who are getting them free from a relative, the source by this report appeared to be one doctor. Okay? So that's just an important thing. So the doctor shopping, that 1.9%, yeah, not so much being borne out as the primary way people get things. And certainly they do. And that's why we have PMPs and we track this thing. We track these PMPs. Does everyone know what a PMP is?
Prescription.
Yeah, so Texas has one, 49 states, prescription drug monitoring program. And these are systems in Texas. I have not seen the new system, just changed the system to be much more real time. A wonderful resource to track opioid prescriptions. And it's done at the level of dispensing. So every dispensing prescriber or pharmacy in the state of Texas is required by law to report opioids with identifying information so that prescribers and healthcare providers can access this information about their own patients and understand if they're getting an opioid from more than one source, and how much opioids they're getting, and the type of opioid. And that's important for diversion and the prevention of misuse and abuse. Okay, I'm going to skip these just because they're not central to some take-home points, but this is a summary that Ben Marasco did looking at the number of patients with the current substance use disorder, just to get a sense of rates. And so if you look at outpatient pain clinics, there's a lot of variability, but outpatient pain clinics anywhere from 11 to 35%, inpatient pain clinic. Primary care clinics, the number is 8, 10, 3%. And HIV going very high. I've actually seen numbers a little bit lower than that more recently, but 50% in the emergency department presentation. Just for those of you who might work with patients on methadone, where we see, not surprisingly, the greatest number of folks if we flip it and then want to look at the number of chronic pain patients in an addiction setting. About a third, and this has been, again, this is an old study from mine from 2008, but this has been borne out repeatedly. About a third, a little more than a third of patients presenting for treatment in a methadone or any type of opioid replacement treatment will have chronic pain as part of their presenting problems. And this is not chronic pain that's been around for 3 months. This is chronic pain that's been around for years and years and years. Okay, so again, assuming that there's some familiarity with pain care, modern pain care principles, this is a relatively new report that came out by the IOM, that pain management is a moral imperative, considering chronic pain a disease in itself, and that a slew of things that need to go on that. One of the things that I think has hampered research is that NIH has many institutes. It has no institute that owns pain. And so we have no dedicated forum for discussing pain issues and understanding pain as more than a symptom, but really in this syndromal way. And that has changed of late because there's now a pain consortium that's across the institutes. And unfortunately, again, sometimes good things happen, other bad things. There's a lot more attention about pain because of the problems that we've seen in this country with opioid analgesic misuse. And I think the benefits, the fruits of that research are just beginning to come out now. I've already mentioned that pain is a subjective experience. It's important that appreciate that pain tolerance varies from person to person. One thing I did want to point out, and the reason I looked this in, is that physicians are nearly twice as likely to underestimate pain in Black versus white patients. Why would that be? So it speaks to this issue that I think it highlights, in addition to pointing out a health disparity, it points out that evaluating pain, sometimes we're not always that good at diagnosing pain, at judging a patient's perception of pain and what's going on with the situation. Right now, a lot of scales are based on how severe is your pain, a scale of 0 to 11, 0 to 100. It's really important to consider in your assessment the functional impairment. And so in my research now, I no longer I do pain outcomes. In my trials, I no longer power studies or design my research to look at pain severity because I don't actually expect anymore a reduction in pain severity. And I've come to decide that it's no longer important to me whether the pain goes down. I'm sure it's pain, but it's poor for the patient. And so we look at it. But I find that what I need to do is look at pain function. And if people are enjoying their lives, if they're engaged in activities, if they're getting out of bed, this whole idea of functionality becomes more important and more salient to the patient the more experience they get with improved function, so that the importance of that pain severity starts to become less. Does that make sense? Mm-hmm. Am I preaching to the choir? I realize this is a general, you don't realize your specialty is broad, so I'm sure I'm telling you things you already know. So just again, going to my population that are near and dear to my heart, the folks with a substance use disorder, unfortunately we just don't have a lot of information about how best to treat chronic pain in this population. And the illustration I would give for that is, I've worked with people that I still remember this woman with spinal stenosis and that needed surgery. And the physician was really recommending, she had a history of alcohol dependence, alcohol use disorder, and was terrified to take pain medicine, and was making choices about her pain care because, that were based on she was so nervous about taking a medicine or even having a surgery because she was worried that any exposure to pain medicine would put her on that slippery slope back to addiction, and she worked so hard with her alcohol recovery that she didn't want to compromise that. We don't know whether it's better to treat someone with an opioid to help them with their pain in recovering from surgery or other things. Is that actually protective against relapse for that alcohol use disorder, or is it actually dangerous to expose them? That's a pretty fundamental question we should know the answer to, because we know that people use alcohol for pain relief, and actually we put out a study saying that this was a couple of years ago, but the most frequently recognized pain relief source for elderly populations was alcohol. So do we want them using alcohol for pain relief, or do we want them using a monitored, trialed dose of an opioid? We don't know the answer to that. I know for me, alcohol use has a lot of issues with it, including disorders, so we just don't know what the right decisions are for people with substance use disorders. The two studies that have addressed pain and relapse prevention did help reduce pain, improve function, and reduce relapse. What we're looking at more and more is, rather than think about it as you've got a misuse problem or a diagnosis of a substance use disorder over here, and you have chronic pain in this bucket, how can we integrate care, and how can we have a pain-related opioid use disorder? So we're almost putting it in one context so that people can really understand the functional relationship between the substance use problem that they're having and their seeking of pain relief. And are there other strategies that they can employ beyond the opioid that either will help get their opioid use in check so that it's following what the doctors prescribe, or removing them entirely from the opioid? Well, this one actually I will cover. So, in an integrated care model, have folks seen this model before? Okay. So this is adapted from a comorbid physical issues model, which is where you look at both disorders on a continuum from low severity to high severity, and you help to make treatment decisions based on that. Unfortunately, for people with a history of a substance use disorder, if they start to have problems with opioid misuse, it has been the case that the primary care providers are unwilling or concerned about providing care for them and continuing to prescribe an opioid. Unfortunately, that sometimes puts the patient at risk for an opioid use disorder, even if they're not exhibiting one at the time. They've just, maybe they've popped positive for something that they weren't supposed to do in a urinalysis, and then the provider who was writing the prescription for the opioid no longer provides them the opioid. We've got a problem finding access to substance use programs, and then people have trouble. But generally speaking, when you have low pain, low SUD severity, current or past, in primary health care settings, there might be, that seems appropriate as long as their chronic pain severity is low and their opioid use disorder is low. So consultation with a substance use provider might be an appropriate level of intervention. But as we start to see people increasing in severity with either the opioid use disorder or the chronic pain disorder, we get to the point where if they're high pain and high substance use severity, it's not abandoning one problem in favor of the other. It's keeping both on the table and understanding how to come up with a collaborative care model that will be appropriate. But how easy is it to get people into a pain clinic these days? Is it tough? Yeah. And how easy is it to get into a substance use program? I mean, this is unfortunately the problem that we face. I know the public methadone program that I work with has they've stopped adding to their wait list for methadone. And I think when they stopped adding to that list, when they closed the list, they were at 100 to 200 people on that waiting list. It's a very stable population of methadone users, and so it's very difficult for new people to come in. So unfortunately, it can be a challenge to get these referrals made. So what we generally say when people have a pain history and they are seeking treatment for a substance use disorder, the key is not to ignore the pain. Remember what it's like for someone with an invisible phenomenon like chronic pain in many ways, to have someone say, I hear you're in a lot of pain. Let's figure this out and let's figure out what we can do. that means a lot to folks with a substance use disorder. I will tell you time and time again, if somebody has addiction in their chart, they are sitting there waiting for the provider who they see to note that and treat them differently because of it, even when they haven't done anything aberrant at that time. This is a remote history. You know, when I can, the patient that was in a group of mine a few months ago that said that they put addict on a sign outside their door of the clinic. Not anywhere with our system, but they labeled it so that when she was recovering, they wanted to make sure nobody made a mistake and gave her too much pain medicine. That was on. She had a picture of it. It's important to ask about any treatment history, including current prescriptions, and consider the relationship between pain and substance use, even non-opioid substance use, which I've already talked about it. And incorporate pain into your treatment planning, even if it's just checking on how their pain is doing as they're progressing in the substance use treatment. It's also important to recognize, and again, I may be preaching to the choir here, there are very, very few, if any, randomized controlled trials of opioids long-term for chronic pain. And the ones that do seem to have that type of, that we do have that give us some information, it's very unclear the efficacy of opioids for chronic pain. And again, I'm speaking this big bucket of chronic pain, but the biggest area where we see opioid misuse is in musculoskeletal pain. So it's usually low back pain, lower extremity pain that might be radiating from the lower back. It's not often with headaches and things like that. It's where you would expect to see it. It's with people with musculoskeletal pain, being prescribed opioids and developing problems with them. What we know for that is that opioids actually aren't that effective. They're not, very rarely are they 100%. And very rarely do you even get 30% pain relief from exposure to an opioid. Yet people are put on these medications, unfortunately, in some settings, and they can be on them for a number of times, for months, if not years, based on a refill. And there's not enough approaching this as a trial with evaluation. We'll try you on the opioid, let's see how the medication does for you, and then we'll evaluate whether it's appropriate to continue on the opioid. That type of approach, unfortunately, has not been happening. So the APS, again, is this all familiar? You know all this. So this is, just because I don't want to just sort of beat you over the head with things. So one thing about opioid prescribing, and this is strong recommendations based on weak evidence because we don't have a lot of empirical evidence to support these recommendations, but they seem like reasonable universal precautions, is when we are prescribing opioids, a clinician who accepts primary responsibility for medical care, engage in an informed consent process. An informed consent, when we're talking about opioids, I've got a slide that talks about that. I'll talk a little bit more about it in a moment. And then continue, as I've already said, to reassess the patient, including documentation of pain intensity. So you can actually have that. If you collect that information in real time, when the patient says, gee, I'd really like to keep using this opioid, no, it definitely helps. But then you go to the record and it says, gee, every week you've been at a 9 on your pain scale and you continue to have functional impairment. I'm not sure this opioid is working for you. Maybe it's time to try something else. So this gives you that opportunity to speak to them with data. Okay, so again, it's moving towards this trial approach. What I believe from an addiction perspective, as a psychologist, is behavioral monitoring is one of the most important tools we have in working with people. So this type of documentation is helpful. It's particularly helpful if something comes up in a urinalysis, like medication that should be there, if it's not there, or medication, an additional opioid that you weren't expecting, or cocaine, for example. This type of data can be helpful in those conversations about what you're going to do next with the patient. For high-risk patients, urine drug screens or other information to confirm adherence. I'm a big proponent of mandatory, universal, random drug screens. It's destigmatizing when it's random and universal. Or that there's some sort of upfront protocol that's identified that selects a certain subset of people based on risk and puts them on that protocol. It's an open conversation that explains it to them. They then have the choice as a patient about what they're going to do. They don't need to see you. But if they see you, this is my policy. Okay. And this can be simple. There was one physician that I met a couple years ago, and he rolls dice. So when they come in and he sees them, he just rolls the dice. And if the dice rolls doubles, they get a urine test. It's It's not the fanciest. I don't know what his dice were like, but I mean, at least it creates this perception, and as a teaching tool for the patient, it gives them a sense that this is not personal to them. Yes.
What did you do with the buried UDSs? Because that's what we come up against is, you know, you have different things in there that some are more serious than others.
Mhm.
And, you know, a lot of it is if, whatever it is, like you're cut off or you're tapered, is that what you do in your
Yeah, I mean, I think
practice?
the recommendations and general practice would be that it's important to have a policy and stick to the policy. And that people know this gets to informed consent. People understand the policy in advance, upfront, before there is any problem whatsoever, so that you have something to go back to. The challenge is that when you're actually with the patient, that's a lot easier said than done for some folks. And I don't know, here I do some work with Barbara Taylor, and she said, talking about when they're cutting folks off opioids, they make a decision to cease the treatment. There can be, patients can become very agitated, they can become very aggressive, and it can be an ugly conversation. If you're interested, and I can send it through Mark, there's a wonderful series that NIDA worked on with Drexel, and it's all online and it's free. And it's actually training and motivational interviewing and strategies around having that conversation with the patient. And what they recommend, and they do very nicely modeling it with the physicians who do it online, is I am not abandoning you. Opioids are no longer a part of the treatment here. That does not mean that I'm leaving. It does not mean that you're going away, but it has come to the point where the benefits of giving you this are no longer less than the risks because you are displaying these behaviors. And what we know is that, and then it's the broken record technique. It's the same thing.
Mm-hmm.
The challenge becomes is having a universal policy on this that's up front. And just on that note, because I am running a little bit at a time, these are some other, and I always put too many words on my slides, but I'm usually used to people taking the PowerPoints out, and so I want the context on the slides. So forgive me for those of you who like bulleted slides. This is an opioid agreement, so an informed consent, an opioid contract, and I quite like this one. It's goal-directed. If no change after a specified period of time of increasing dosage of opioids, consider stopping. Multimodal management of pain is part of the agreement, even if that means that I am going to write this prescription for you, I want you to do these other things, or I want us to talk about what other things we can do. If nothing else works, that's one thing, but we want to see demonstration of behaviors that mean that they're actively engaged as a patient in doing other things that are recommended. Even if that means yoga, it doesn't necessarily mean going to a healthcare provider, even if it means going to the community center and doing something, even if it means walking. Whatever it is that's appropriate to that person. Doesn't mean they have to go to 5 providers and go to a pain clinic and get referrals. It might just be walking 5 minutes a day. They can show how they've done, they can track it in their calendar, or they can just come and report it, depending if it's something else. And that the agreement needs to design use and refill guidelines, follow-up guidelines, single prescriber pharmacy, no illicit drugs or diversion. Up front, just say it for everyone. Safe storage, that's protection for those around them as well as for theft. UDS, and that the prescription monitoring program will be used. And the more that that's done up front, the less it becomes something that's a barrier. The way we found it most useful to frame it is this is safety. It's safety for our community. It's safety, it's like hand washing. You know, it's just what we do.
I think the VA pain agreements have all of those components.
I'm sure you really do. Okay, so for folks with a substance use history, that's the last one. Frequent visits, small quantities, to the extent that that's possible. It does not need to be, so you can, it is appropriate in some instances to say, I will give you a week and I'll see you come back. And that you adjust what you do with that patient based on the behavior that you see them exhibit. And then taper the visit schedule. But it is important to at least consider frequent visits in smaller quantities. My classic example is the dentist that I went to, an endodontist. I was having horrible pain and I really wanted an opioid. And really wanted an opioid. And I ended up having to have surgery. And I said, can I just have a couple days and see if that helps beyond what the NSAID is giving me? And he wrote me a prescription for 30 days. And I said, I don't need that much, I just want a couple days because the antibiotic's going to kick in. And he said, you just keep that in your medicine cabinet, you never know when something's going to come up. because I don't look like a drug addict, apparently, I guess. But so those types of things happen. I think this happens less and less, but it's just important to think about. You don't have to write. For the long-acting drugs with no rescue doses, this is a guideline. There's no actual definitive evidence that long-acting doses we think this is the fact, that long-acting are better than short-acting in terms of mitigating opioid misuse risk. But we actually don't have a lot of data to support that. But there's some other use of one pharmacy, pill bottles, no replacements or early scripts, use of gerontology, and coordinating with the sponsor. These things in particular can be very, very useful for someone with a substance use history. If they have been clean and sober for 5 to 10 years, and they've fallen away from AA or whatever it is that they might be using, this might be a time to just do a little check-in and avoid PRN dosing. PRN dosing is behaviorally, it's very reinforcing, PRN dosing, because it puts what's called an intermittent schedule of reinforcement. And so keeping people on a fixed schedule of dosing actually is less reinforcing for reinforcing of a behavior. It's a less reinforcing behavior, and as a result, it's better for someone with a substance use history because of the learning component within addiction. And I think I'll stop. These are some other things we can talk about. These are some great resources. This is old but terrific. Seven Savage used to be president of the American Pain Society, wrote a wonderful explanation of the intersection of all these things along with our colleagues. And then this is from, this is again a little bit older now, but Jane Valentine here in chronic pain, and then this one here. This was actually from the College on Problems, Drug Dependence, and Physician Statement from the addiction side of it. So hopefully we have up to a few minutes for questions. So that's my shtick. I've got some other things in here. If people are interested, this is a trial that we did establishing, we think, hopefully definitively, that it is possible to put somebody with chronic pain into a buprenorphine treatment trial and see them respond very well to the addiction treatment using buprenorphine, but also that their pain actually doesn't get worse. They tolerate it very well. It's very safe. We had no difference in folks with chronic musculoskeletal pain or any other type of self-reported chronic pain. We had no difference in SAEs on buprenorphine treatment, and we had pain reduction along with addiction recovery. So buprenorphine, in this sense, can be very effective for the treatment of a substance use disorder in someone with co-occurrent chronic pain, even fairly significant chronic pain. And the slides are all there if you want to see. So that's me.
Do you have a preferred opioid sort of risk tool in terms of, there's various canned ones you can use, but do you have any recommendations regarding that?
No, which one do you use?
I actually have to look them up each time because I've just started doing it.
So there are a couple, and there are a lot out there. Steve Pasek, I think, has a great paper I could send along that has some recommendations. They're all mediocre, to be perfectly honest. So for assessing risk in someone who would be new to being initiated, I think the SOAP, S-O-A-P-P, that Bob Jamison did is about as good as anything. I actually like, I didn't present the slides here, but I've used the CALM a fair amount, and the CALM is the current opioid misuse measure. It was actually developed, it's free to clinicians off of a company called Inflection's website, INFLEXXION.
Yeah.
And the CALM I like because it gives you a really nice conversation, and it's designed to capture misuse risk in the present moment. There's some problems if you're going to say, you're misusing, because I don't think all of the questions are misusing indicators, but there are only 16 or 17 items. The cut point is very clear. It's very sensitive. So the cut point to get to where you're signaling misuse is I think we did it in the pain clinic here, and I think 74% of people, absolutely no one here is misusing. But when we did that measure, 74% of people hit the cut point and above. So it's a little sensitive. But when you 16 items, you can actually look at them and see the ones that might be of concern. Because some of them are, I've thought about suicide, or I've thought about ending my life, which is, I think, a little bit more of a marker of mood than it is misuse. But some of them are, I've gone to the emergency room, I've gone to this. The trick with the screening tools is that if somebody actually knows that they're misusing, and they want to continue to have that, even if the misuse is not abuse, even if the misuse is just they want that medicine because they think it's functionally helpful to them, and they're not necessarily on that path towards addiction, they know that those answers are going to trigger a conversation. So people can be very afraid to answer those questions openly and honestly. So you have to take those with that in mind. So it's tricky because you're sort of searching around. When we did it anonymously, the reported misuse was much higher than anything that clinic had thought that they would see, but it was anonymous. But I think the comm is pretty good for having a conversation, and it's quick, it's easy, the literacy level is good. You know, but people are afraid, people are terrified that you're going to take their medicine away. I mean, don't you find? Because that's their lifeline, and that education about that's maybe not helping them as much as they think. People have been doing this for a long time and taking these medicines, even for someone who's not misusing, who essentially is being stabilized on some opioid dose. They're dependent. It might not help their pain at all, but they've been taking it for so long. To start to think about no longer having that, and imagine as people get older, it seems a little silly not to recognize that some of these folks have very long, pronounced histories of opioids. So the SOAP and the COM, I think the ORT is fine. There's some that are actually physician-based, where the physician can actually, or provider-based, and can evaluate certain behaviors based on that. But I think they're tough. I think in some ways it's easier to know if there's a psych history, family history.
Are there any changes with age in terms of like who develops a substance abuse disorder in the setting of being treated for chronic pain?
In the setting of being treated for chronic pain, so substance use disorders usually overall emerge when people are younger. It's like more unusual to see someone in their some gender differences in people in their 40s and 50s than it is to see someone in their 20s. Just like a lot of behavioral phenomena, they tend to emerge earlier. There is a lot of, I think what's difficult in older populations is that I'm trying to say what I know and not what I'm speculating, so bear with me for a second while I make sure that I think the trick in an elderly population is some people have been stable on things, and there might be other presenting problems that are more important than being concerned about someone who's been on 40 milligrams of Vicodin for the last 20 years. It might not necessarily be the case that that's great, and they might have even escalated their dose, but people come to us in complex patterns. But there is a robust evidence that misuse of prescription opioids among the elderly is a significant problem. I think what's the challenge is what to do about that. And I think that unfortunately sometimes we can end up causing more problems by addressing that and removing their opioid and not necessarily understanding everything else. Does that make sense? So it's complicated. But I go back to, I remember I did a consult on the Geri Psych unit, and this woman, she was 92. She was totally addicted to benzos. She was abusing them, she was stealing them, she was doing everything. But the reality was she sort of self-stabilized, and that was, she had her little places where she got them in this, and she had a lot of other significant issues in her life. And at that point, me attacking her drug addiction might not have been, maybe this is controversial, but that might not have been what I would have chosen to do, given that she wasn't hurting anyone. She's 93 years old, and if we took that away, she had a profound anxiety problem, a significant anxiety disorder that had never been treated. And the treatments that we have behaviorally aren't necessarily that successful in that age population. So, my 2 cents.
Okay, and with that, time is up. Thank you very much for that.
Thank you.
Be sure to sign in, receive an evaluation for today's talk.
Oh.
And if you are attending, be sure to sign in for credit for today's talk.
The what? I didn't either. What's up, Dr. B? How you doing?